of all. Yes. Now you can start.
A very good evening, everyone. I, Dr. Misbah Kadri, and Shubham Bharti will be the moderators for today's session. We welcome you all to the Cynodent Webinar Series 2023. Theme of the series is Unlocking Trends in Dentistry. I welcome Dr. Sanjeev Kumar Sararia, sir. He is the professor at Department of Periodontology. Topic for the session is Dentinal Hypersensitivity and Update. I would like, sir, to please start with the presentation.
Thank you, Dr. Kadri. First of all, I thanks Dr. Anmol and Dr. Ashish for giving me the opportunity to host this webinar. And special thanks to Dr. Kadri as well, who is communicating from the last 1 month with me to host this event. Thank you very much. Am I audible right now?
Yes, sir, you are audible.
Okay. So the topic that what I choose is the dentinal hypersensitivity, as we most of us we are facing in day-to-day oral hygiene effect, that the dentinal hypersensitivity is the one of the common finding that the patient reported. From starting with the definition, because there are different terminologies regarding the hypersensitivities used in the dentistry. But it is better to understand the definition first of all. And because this definition gives you the details that what actually it was. It was a sharp type of pain that arising from the exposed dentine in response to any thermal, evaporative, tactile, osmotic, chemical exposure, which cannot be ascribed to any other form of dental defect or pathology. That means it is typically an dentinal exposure which has been hyper-reactive in nature. And this definition has been modified by the Canadian Advisory Board on Dentinal Hypersensitivity in 2002. As the dentinal hypersensitivity is the common finding that the patient reported to the clinics most of the time, but no definite treatment is available till date in literature, and to certain extent there are lacuna in understanding which type of sensitivity is managed by which type of treatment modality. But before we jump to the treatment modality, we should understand the nature, why the dentinal hypersensitivity is known as dentinal hypersensitivity rather than using the terminology dentinal sensitivity and root sensitivity. Dentinal sensitivity is the terminology used by most of the clinicians who think so. Every dentine that what is getting exposed in the oral cavity is sensitive to the nature. So why we are using the terminology dentinal hypersensitivity than the dentinal sensitivity? Whereas the root sensitivity is something different than the dentinal hypersensitivity, as both of these terms will never fulfill the definition of dentinal hypersensitivity. Remember my words. So why it is known as dentinal hypersensitivity? Histologically, lesion of dentinal hypersensitivity, it is not only the lesion that is exposed in the oral cavity, but at the same time, it should have two different perspectives that we are coming in the coming slides. One is the lesion localization and another is lesion initiation. So any defect that is visible or dentine exposure is visible in the oral cavity, we can say it is a dentinal lesion. It may or may not be sensitive to the different stimuli that we come across in the daily day-to-day oral hygiene and oral day-to-day activities. Whereas the root sensitivity is the terminology used where periodontal disease is present, or it may be a post-therapeutic periodontal therapy associated. One of the common reversible finding type or irreversible finding in terms of periodontal disease. So dentinal sensitivity is differ and root sensitivity is differ than the dentinal hypersensitivity as such. For that, the dentine is not only required to be exposed in the oral cavity, but it should have number of dentinal tubules, more number of dentinal tubules available at the dentinal surface, and they are patent to the pulp as well as, so that the fluid movement within the dentinal tubules will limit and it should be expressed to the pulp that is known as hyperreactive dentine. That's why it is known as dentinal hypersensitivity rather than the dentinal sensitivity or the root sensitivity. Be it the dentinal hypersensitivity or root sensitivity are same as we all discussed. So if these two are different than the dentinal hypersensitivity, it means their management also differ for dentinal sensitivity and root sensitivity rather than the dentinal hypersensitivity. So before we jump to dentinal hypersensitivity treatment modality, we should understand the physiology of the dentine, which is the most important to understand the dentinal hypersensitivity. It is well known fact that the enamel never responds to any stimuli, but when this stimuli reach near the dentino-enamel junction, a sharp pain is felt, which indicates the difference between the enamel and dentine because responsiveness of the tissue is the primary concern. And in most of the SCM study, it was observed that if the dentine is exposed, it may or may not be sensitive. And when it is hypersensitive in nature, and on histological evaluation, it was evaluated that the the number of dentinal tubules are increased in number, and they are more near the cervical surface of the cementoenamel junction, and their diameter also getting wider. So these two terminology make the tooth or the exposed dentine more reactive towards the stimuli, and that the way they induce hypersensitivity reaction or hyperreactivity reaction, which is known as dentinal sensitivity. And it is a sharp type of pain which indicate the difference between the enamel and dentine because of responsiveness. When we come about the pathogenesis, I have already there are two processes that are indispensable for the development of dentinal hypersensitivity. One is lesion localization. That means the dentine must become exposed, and the dentine initiation. That means the dentinal tubule must be open to both the oral cavity as towards the pulp. Only then they are able to. And they adding the pathogenesis, there are three hypotheses proposed: odontoblastic transduction theory, neural theory, and hydrodynamic theory. We all are familiar with, but we are not exactly knowing, and we are trying it by hit and trials to change the medication or change the antibiotics. But we should understand, first of all, the diagnosis is appropriate or not. If our diagnosis is appropriate, only then we are able to treat the lesion. So if the diagnosis is inappropriate, because the typical pain that's alleged with dentinal hypersensitivity may be collaborated with other differential diagnosed disease, which are representing similar type of issues of patient concern, but the treatment modality may be different than the dentinal hypersensitivity management. So, first of all, the odontoblastic theory, it is failed to justify their hypothesis in which they say the odontoblast process is exposed to the dentine on stimulation. They release certain neurotransmitter towards the nerve ending, but it was never observed histologically and biochemical evaluation. So, this theory will get failed on their own hypothesis. Whereas the neural theory say the nerve ending within the dentinal tubule, which have direct communication with the pulp nerve fibers, are directly stimulated on mechanical and thermostimulation. Although uh, unmyelinated nerve endings or nerve fiber have been shown to be present in the root dentine in some of the observation, but it will never observed in all the cases. So this theory will also remain more of, you can say, the theoretical concept rather than the clinical and practical aspect. Then comes the hydrodynamic theory. That is the most widely accepted theory in which they say, no doubt, the neural fiber has been observed, but has been observed in close proximity to the pulp. That means the dentinal tubule ending, which is more towards the pulpal side, they contain a few fibers, maybe from the pulp or maybe from the C type of unmyelinated verb, but the whole of the tubule get filled with the fluid. And when there are certain physical or temperature changes, or you can say osmotic changes taken place in the oral cavity, the fluid movement get disturbed and they are moving in or out. When they are moving out from the pulp side towards the root surface, the sensitivity to cold will taken place. And when it moves towards the pulpal side, that means the heat transition will be taken place. So we should listen to the patient when he complained about the pain. So we should take the history of pain appropriately, that what is the pain intensity, what is the duration, what is the frequency, what is the precipitating factor, what are the relieving factors. If there is nothing except you can say while brushing or while stimulation, the pain elect and immediately after that it stop without taking any medication, the most probably they are, that is the associated with the dentinal hypersensitivity, maybe because of abrupt toothbrush, associated gingival session, or exposure of the cement or enamel junction. So diagnose on the behalf of clinical finding, or you can say thus clinical feature that patient present. So we should give more valuable concern to the patient's issue, that the patient reported with what finding and what he is convincing and what symptom he is disclosing to the clinician. So first of all, we give the patient the time to express his feeling, and we should listen carefully which type of pain actually it was. It may be a pulpal pain or it may be some other pain. So we should differentiate first of all, and then we proceed further regarding the question regarding the pain frequency, intensity, duration, precipitating factor or aggregating factor. What my point? Then come the etiopathogenesis. When we are talking about the etiopathogenesis, there are different issues that may be one of the cause for electing the dentinal hypersensitivity. It may be a non-surgical or post-surgical treatment of periodontal disease associated dentinal hypersensitivity. It may be tooth wear or gingival recession. You can say the wasting diseases. It may occurring post tooth bleaching. It may be because of developmental lesion, or it may be because of oral hygiene and gingival recession associated causes. That may be the most probable etiological factors that may elect the different types of dentinal hypersensitivity. It was routinely observed that normally the smear layer was formed by the collagen and glycosaminoglycan, which are normally present in the saliva, and they layer the mineralized tissue and occlude the dentinal tubule in most of the cases. Pashley has reported that in health, the smear layer reform and prevent almost 86% of the dentinal fluid movement, and thereby preventing the dentinal hypersensitivity to occur. But if the patient is having periodontal disease or treatment, these periodontal disease associated bacteria and their co-product may colonize and break down the smear and penetrate into the root dentine, which might initiate the inflammation in the pulp. But remember, the dentinal exposure through unhealthy gingival session cannot be included as a dentinal hypersensitivity, and but it should be associated with root sensitivity. So we should acknowledge that thing, that which is root sensitivity, for which required and consultation with an periodontist, and he will give an appropriate therapy for the management of root sensitivity, rather than we try to our hook and crook methods to get rid of that. Then comes the clinical presentation of dentinal hypersensitivity. As we already know that it is a sharp type of short pain that arises from the exposed dentine in response to the various stimuli, which cannot be ascribed to any other form of defect or disease. The definition itself explains the clinical feature that it is a sharp, short duration of pain which elect from exposed dentine, and the later part of definition eliminate all the conditions that have identical symptoms but not the treatment option. Then comes the condition that presenting similar and overlapping symptoms that might confuse the clinician. What is dentinal hypersensitivity and what is sensitivity, or what you can say what is root sensitivity associated with other disorders. there are wide variety of conditions, or you can say the pathologies, which elicit an overlapping symptoms. Similarly, like dental caries, fractured teeth or restoration, cracked tooth syndrome, pulpal response to the caries pulpitis, postoperative sensitivity, improper isolation of metallic restoration, incomplete placement of dentinal adhesive in restorative dentistry, including nano leakage, palatal or developmental abnormalities, or typically hypoplastic enamel or congenitally open cementum enamel junction are the condition which may elicit symptoms similar to the dentinal hypersensitivity, so that we should clinically differentiate all of these before attempting the treatment for the management of dentinal hypersensitivity. But concisely, on clinical evaluation, there are two types of evaluation. One is subjective, in which we are taking verbal analog scale, in which we can mark it with the 0, 1, 2, 3, 4, and we simply ask the patient how much grade of pain you are supposed to grade from 0 to 3. If it pertain for more than 10 seconds of air exposure at a room temperature to the area of sensitive dentine. Other is visual analog scale, in which the patient can see the scale of 1 to 10 and tell about the limit of pain, that the experience of pain from external stimuli is how much marks he was supposed to award out of 10. Then the verbal analog scale is similar that what we have discussed in the next session. Objective assessment can be evaluated by mechanical or tactile stimuli. Normally, we are using the sharp explorer, but most of the time, because of the patient's doctor's physique or doctor's adaptation of the stimulator on the explorer on the dentinal surface, ideally 5 to 10 gram of force should be applied to the explorer, and it should run freely over the dentine surface, and it can be used 2 to 3 times, so that it will induce any changes within the dentinal tubules, and it can be reassessed. Differential diagnosis, if we see all the conditions which are overlapping, but most these 5 or 6 criteria which may be elucidated before attempting the dentinal hypersensitivity, maybe a cracked tooth syndrome, which may or may not be visible clinically. Just a minute. But it can be evaluated with your expertise and clinical experience through the dye inoculation. We can easily clinically evaluate the fracture restoration, chipped teeth, dental caries, post-restorative sensitivity, history, and teeth in acute hyperfunction. These are the differential diagnosis before we attempt the dentinal hypersensitivity management. Treatment of hypersensitivity, mainly, as we earlier also declared, that adequate diagnosis is the prime requisite for the management of dentinal hypersensitivity, and the prophylactic measures are essential for successful outcome and need to be supplemented with long-term follow-up. But most of the time, what we observe, the patient once taken a medication or recommendation from the doctor for the hypersensitivity management, in India, most of the clinicians, they are not follow-ups. And most of the time we think so the prescription what we made is appropriately working. That's why most of the time the patient will not return back. But this is not right all the time. And almost 90% patient may shift from one dentist to another. By the time it will be more chronic, and slowly the pain will subside automatically, and because of multiple application or different type of dentifrices or recommendation as made by the dentist, at the end the patient is still in dilemma what to do. And at the end, when the patient is coming again and again, and we are not able to manage the dentinal hypersensitivity, most of the clinicians, they prefer to go for pulpectomy, or you can say the root canal treatment, to get rid of the same. Otherwise the patient will trouble you. But that is not the ideal standard treatment that we should follow. We should acknowledge by adequate diagnosis, and once the diagnosis is achieved, almost 90% targets of management of dentinal hypersensitivity is in your hand. and then you can plan what is the best treatment available in the literature. There are factors such as biocomposition and flow of saliva, dental plaque, acid production, self-cleansing, and demineralizing potential of the oral cavity that can also impact the chances of reoccurrence. But most of the time, we are recommending recommendation, but we are not guiding the patient to take these steps as a preventive measures so that the effect of occlusion of dentinal tubules and the management of dentinal hypersensitivity will sustain for a long time. So, if they exhibit a positive response, exclusion of the pathologies and treatment of dentinal hypersensitivity should be initiated. But the treatment efficacy of active agent used for, there are different types of materials available in the literature, and major strategy for the management of dentinal hypersensitivity include the patient education and behavior modification. That is the first lacuna that what we are encountering in most of the clinical setups. We are simply delivering the prescription, but not educating the patient and not recommending and follow up the patient for behavioral modification, because first line required multiple visit and multiple motivational steps to be motivated again and again so that they will rectify their faulty habits. Got it? Non-invasive treatment, non-invasive treatment, non-invasive treatment for the occluding the dentinal tubule relieve the pain associated with the dentinal hypersensitivity, and there are other treatment like restorative or surgical treatment for the management. But here we are, in addition to the treatment management, we should also looking for certain factors that may be taken care when we are recommending our educational and behavioral modification to the patient. That include avoiding toothbrushing, periodontal treatment patients, patient with abrupt dietary habits such as bulimia. Bulimia is basically when the patient is systemically very conscious and is taking diet very precisely. 50 grams of protein is required, 100 grams of carbohydrates are required. Such type of patients are also suffering from such type of disorders. Older patients, smokers are considered to be highly susceptible for the dentinal hypersensitivity. So these factors will also given due consideration when we are educating and doing the behavioral modification at every interval till the patient satisfaction level is achieved. Patient should be educated and consult behavior modification depending upon the use of correct toothbrushing technique, including the selection of toothbrush and the dentifrice. Advise the toothbrushing technique before consumption of the acidic food, at least, if not possible, at least 1 hour before the intake, but it should not be used immediately after the beverages, because the pH of the beverages is most of the beverages approximately 2 to 3 pH, which is more acidic. And once you do the brushing immediately after that, it will lead to the huge amount of loss. So avoid excessive pressure. Parafunctional habits should be taken care, and if they are present, we should consult an orthodontist, and if required, occlusal splint should be provided. Encourage and monitor the patient's diet to quit or reduce the acidic food intake, and always recommend to use alkaline foods such as milk and the water containing, more water containing foodstuffs that can easily flush out the acid that normally produced by the plaque microorganisms in the oral cavity or by the dietary changes. If they are able to control it, it is better to use the straw instead of taking it directly from the oral cavity so that less of communication between the teeth and the acidic food will come. The patient with systemic eating disorder should refer to the medical consultant for the rectification if possible. Then come the active dentine hypersensitivity management. Primary goal of objective is the cause related therapy. That means we should we are very well aware that the hyperreactive dentine, because of which the dentinal sensitization will take in place, it may be because of increased number of dentinal tubule which is open to the oral cavity as well as towards other end is towards the pulpal side. In addition to that, their diameter will also increase. So our prime focus should be related to the cause related therapy. We are trying to, and various medication till date whatsoever is available, either they are you can say the self administered over the counter prescription, or the dental professional, most of the things they either cover that area, or you can say they desensitizes that area by giving certain medicament associated dentifrices, which can act either on the neural fiber activity towards the dentine hyperactivity, or either they are going to occlude the dentinal tubules. But first of all, the non-invasive therapy most of the time and most easily available, and it should be easy for the patient, is the various type of dentifrices which are desensitizing dentifrices available in the market, including desensitizing mouthwash. And nowadays the herbal are getting more popularity because now the research has been restarted, and they find out there are certain products which can also have good efficacy in maintaining the dentinal hypersensitivity. These are the different types of active ingredient containing dentifrices. Some dentifrices contain glutaraldehyde, which are having nerve desensitizing action, although the nerves has been not recognized in histological section, but the patient getting relief from the that, but exact cause of the same has not been evaluated yet, and we are not able to recognize why it is going to affect, although it is not going to close the tubule and they are not going to reduce the number of dentinal tubules. Got it? And then the silver nitrate, zinc chloride containing strontium chloride, potassium nitrate, these are all protein precipitating factors, and they try to occlude some part in addition to the nerve desensitization. Whereas there are certain dentifrices currently available, like you can say the Colgate Pro Relief is there, then we can say the Sensodyne Rapid Relief is there. They contain strontium chloride, they contain you can say the potassium oxalate, bioactive glasses, and various other components that have capacity to occlude the dentinal tubule completely or partly. But before we jump to the, you can say, which dentifrices to be used, we should always prefer to read the different types of randomized controlled trial, or we can always go for meta-analysis, or you can say evaluation of, you can say the advanced uh, review articles, which can not only a single participation, as I have already shown on the screen. The meta-analysis has been taken on 53 randomized controlled trial in almost 5,000 patients in 2018. They reported that the toothpaste with active ingredient targeted for dentinal hypersensitivity management show a greater reduction in sensitivity score compared to the negative control, except in cases of dentifrice which contains strontium plain, or you can say the calcium phosphate component. But nowadays there are two three dentifrice which are most commonly using nowadays. One is Colgate sensitive, which contain arginine, is an active ingredient. It has a capacity to occlude the dentinal tubule, and it will never go for demineralization again once get exposed to the acidic beverages again. Second is most commonly nowadays it is coming from the last 1 decade, the dentifrice containing fluorocalcium phosphate silicate. They are also having same occluding capacity, and they are also resistant to the further acidic challenge. That means the efficacy time and the longevity of dentinal tubular occlusion can be best achieved by these type of dentifrices. Then comes the instruction for use of mouthwashes. When we are prescribing the mouthwash, most of the time we always say the patient, these are the prescription, you can rinse it with 10 ml 2 times a day, and that is over. But when we are prescribing a mouthwash, always remember dentifrice, there should be a gap of 30 minutes between the normal dentifrice and clohexidine mouthwash. But when we are using desensitizing dentifrices, the dentifrice and mouthwash can be simultaneously applied also. But there are certain directions or instructions that has to be delivered to the patient for the better clinical outcome. Once they should rinse twice a daily with 10 to 15 ml of mouth rinse for minimal 30 to 60 seconds depending upon intensity of the hypersensitivity. Patient should be instructed to brush their teeth before using the mouthwash. That means, first of all, the brush is to be used, and then later on, the mouth rinse has to be applied. But sometimes we can also utilize the same on the same increment in case of dentinal hypersensitivity, but not in case of plaque control. In plaque control, there should be minimally half-hour gap between the clohexidine mouth rinse and the normal dentifrice, because the clohexidine is a diketinic molecule and the normal dentifrice, whatsoever we are using, it contains certain sodium laurophosphate, which is negatively charged. If you use simultaneously, it will reduce the efficacy of clohexidine and the outcome will be suffered. But in case of dentinal hypersensitivity, we can utilize it with half an hour of brushing, or we can utilize it with simultaneously also. In addition to that, we should ask the patient, recommend it should be utilized for 4 to 6 weeks, but follow-up visit is required for further evaluation on twice after 2 weeks till, and if possible, maximum up to 8 weeks, we can utilize the desensitizing mouth rinse, but not after that. Avoid, and if still the dental hypersensitivity exists, that means we are missing some link in diagnosis. There might be some clinical situation which resemble the similar symptoms that I have already listed: cracked tooth, defaulty restoration, marginal leakage, and old restoration. They can also induce. So we can also look time to time and appropriately manage the case. Then comes the occlusion therapy. Dentinal, as we all know, the most of the time, the patient when undergo the phase 1 therapy and having chronic periodontitis patient, they mostly reported that डॉक्टर साहब आपने तो हमारे दांत ही हिला दिए, और जब से आपने स्केलिंग किया मेरे दांतों में तो ठंडा लगना शुरू हो गया. Always remember, when there is periodontal disease and you are going for phase 1 therapy, transient hypersensitivity will definitely occur. Got my point? So that means before going for scaling, we should encourage the patient that once we do the scaling, the sensitivity will definitely occur, hypersensitivity will occur, because there is an connection. That means the root surface is occupied by the calculus. And once we remove the calculus, the gap between the gums and the teeth is existing. And anything that we consume with and the dentine get exposed, and that will lead to alect the pain or sensitivity, which is known as the root sensitivity. Normally this root sensitivity will wash out with the time within 3 to 4 weeks. But if the patient is hyperactive, or you can say its pain threshold is very less, it is always recommended to use mouth rinse or the recommended dentifrices which containing desensitizing agent for the better clinical outcome, as most of the population they definitely suffer from that. But when the clinician before starting the periodontal therapy acknowledge that that thing will going to happen and that thing will going to improve with time, so the patient is psychologically prepared that this thing will be going to happen with this type of treatment. It may wash out, as doctors say. And if you find out that the patient is having some low threshold capacity of the pain, you can recommend them the desensitizing dentifrice and the toothpaste. Various types of occlusal therapy is available in the market, and what we are doing is a chemical occlusion, or you can say the physical occlusion. Chemical occlusion, you know that the fluorides, various oxalate and glutaraldehydes, agent, etc. There are various other things are available. And physical occlusion means we are restoring that defect. so that there should be no communication between the fluid, and the restoration is lying in between the dentine and the gingival tissue. There are different types of resin or dentine coating agent or glass ionosediments are available. As we all know, the fluoride is one of the goods that can be applied, which not only slow down or stop the decay of progressing demineralization. In fact, it may initiate the early hypomineralized area to get remineralized. These are convenient to use and cost effective, but sometimes they impart certain distinguished color that is not suitable for the patient aesthetic at the time. And certain patients have some allergy to the fluoride as well. But in term of long-term efficacy, because varnish is applied and the oral cavity, the plaque is continuously producing the acid. And what we are taking, consuming and daily dietary habits, they also release certain acid or acidity diet is available that can further varnish has been easily eradicated, and long-term prognosis will not be better. So varnish are not recommended in all the day except in the restoration, metallic restoration, where the marginal isolation has been done with the varnish to prevent hypersensitivity after restorative area. Then comes oxalate. They are also effective in the management. There are systematic reviews available which supported that the 3% monohydrogen mono potassium oxalate containing dentifrices or rest, you can say mouth rinses. They are quietly effective in the management of dentinal hypersensitivity. Then comes the glutaraldehyde. 5% glutaraldehyde. Just a minute. I have some issues. Wait. Give me 2 minutes. It's almost going to end. Just bear with me. So 5-ethyl methacrylate, and its effectiveness has been evaluated and is observed that because it inhibits the discharge of serum albumin from the freshly cut dentine cavity and cause tubular blockage by means of coagulation of plasma protein due to the fixative nature of the RNA. But long-term studies and supporting evidence are not available till date. Then comes the restorative material. There are various minimal invasive restorative materials are available. There are GICs available, resin modified GIC are available, flowable GICs are available, light core GIC are now coming up day. Everyone has their own advantages and disadvantages. But before we want to achieve a good restorative outcome for the management of dentinal hypersensitivity, the following step has to be the mantra for achieving the same. One is isolation is the priority. Whenever there is a moisture come in between the restoration and the receiving surface, the restoration will going to induce dentinal hypersensitivity. So isolation is the prime factor. Then the material selection and its adhesiveness to the dentine surface is the prime concern. Then the cavity cleaning is the most important. If the smear layer is still existing and we are applying the restoration, that will not stay for a long. Adhesion, that means the capacity of the GSE, as you know, is very well adapted and easily get attached to the two structure without any modification. Then insertion technique. When we are preparing a GIC, you know the method of mixing is different than the normal mixing cements. So that will also impart its insertion technique. That means how it should be transported to the site of action. And then the finishing and polishing is the most important. Although there are different types of restorative materials are available, but no statistical significant difference has been observed by the clinician stimulated or patient reported sensitivity reduction in the known caries cervical lesions between the restorations and the sealing treatments. And the last stage, occlusion, and the most important, occlusal approach by the laser in dentinal hypersensitivity management depend upon the three mechanisms of action. One, The laser is effectively changing the neural transmission network inside the dentinal tubule by blocking the depolarization of the C nerve fiber, which has been observed in few cases. Low level therapy, laser therapy such as DOID, impart biostimulatory effect that lead to the secondary dentin formation and tubular occlusion. Sometimes diode laser assisted dentinal melting will also taken place that can also reduce the dentinal tubular diameter so that it will also be effective in the management of dentinal hypersensitivity. High power lasers such as ND-YAG lead to the coagulation of protein within the dentin and ultimately lead to the obliteration of the dentinal tubule. It may be partly or completely. A recent network of meta-analysis of randomized controlled trial indicate that the four type of laser, Arabium, chromium, yttrium, and ND-YAG, Arabium YAG, or dyed laser are the better desensitizing agent for the management of dentinal hypersensitivity than no treatment, both immediately after application and 1 month after the tubule and melting of the dentinal wall has been observed. That means, but we have done many studies in our institute, like SCM studies, scanning electron microscope in vitro as well as in vivo. And till date, we are using the monotherapy or twice therapy for the management of dentinal hypersensitivity. But from my point of view, if we use amalgamation of technique, if you use two different type of dentifrices with a mouth rinse, and if preferably you have a laser in hand, it will going to change the world for you for the management of dentinal hypersensitivity. Laser definitely has a positive and more effective role, but it depends upon the patient's aptitude towards maintaining the oral hygiene and its concern for preventing of the oral disease, which is a prime concern. That means diagnosis, patient's attitude, and clinician knowledge and its implementation is the key mantra for the management of dentinal hypersensitivity. And that's the point where I'm going to stop. And that is the end of the presentation. Thank you very much for your patience listening and have a wonderful day. Thank you very much.
Thank you so much, sir, for the informative and wonderful session, as you explained so nicely. And I would like to thank the founder and CEO of Cynodent Dr. Anmol Bagaria, ma'am, and co-director of Cynodent Dr. Ashish Chandra, sir. And I would also like to thank my co-moderator, Dr. Shubham Bharti. Thanks for all the participants who joined us today. And I kindly request all the viewers to please like, share, and subscribe our YouTube channel for getting daily updates and webinar. Thank you so much, sir.